Hi, I'm Dr. J. Welcome back to the Cash Practice Solution Podcast. And I have a question for you. What if we have to deal with something like COVID all over again? Welcome to the Cash Practice Solution Podcast. I am your host, Dr. J. This week, we're talking about COVID killers in cash practice, which is a subject of tremendous joy for me because despite the heartache that COVID caused, there were an amazing bunch of opportunities that arose that allowed doctors to be heroic, to rise up and do some great things for patients where they didn't have any other resources. But doctors in cash practice, that's right, they were the ones who were able to step up and provide the care. Doctors who were not in cash practice who stepped up, some of them got just taken out. They got removed from their positions. They got fired from their jobs. They couldn't continue. Some of them survived, but there were very few. So today we're going to look at COVID killing from our own unique cash practice perspective. So what should we do for our patients if they have what might be an acute COVID infection? I mean, they came to you for care for sure, right? So what should we do? I mean, this is not like a regular sore throat or a common sinus infection. I mean, what should we do? I mean, you don't need to be nervous about it. They need to be cared for. That's easy stuff. The important part is you want to find out exactly what they want, right? You don't want to follow your path. This is not like a regular old ear infection, right? If somebody comes in with a swimmer's ear, I mean, there's not a lot of disclosure and consent there. I mean, it's pretty simple. Hey, you got a swimmer's ear. I'm going to give you some drops and we'll see you in a week if it's not all better, right? That's easy. This, if you're suspecting a COVID infection, you have a completely different pathway, right? Now we have a different landscape. You're not going to do what you normally do if you think that the patient has an infection of any other kind. This is kind of a special deal. So number one, you do a great physical. There are certain things that you just, because you're good at what you've done and you've done it for so long, you just kind of sail through it. You know you're going to go to that ear, and you're going to go to that ear and look at it, and oh, sure enough, and it is a swimmer's ear, and that's it. Not on this one. On this one, you want to do a very thorough exam. Both ears, sinuses, throat, glandular, chest, all of it. Make sure you do the entire upper respiratory exam at a minimum. If you're suspecting COVID, inspect the gut, because we'll get into that a little bit. It's a big part of it. Do a great physical. Never miss the pulse ox, right? You know, pulse ox is I think you can get them for like $28 now at Amazon, maybe less, but they're cheap. They're almost free. You should have one in each room. If you have 2 or 3 rooms, one in each room at least, and rule out the simple stuff. You might have a patient who surprises you. Maybe you don't know them really well, or you just haven't been paying attention, and their pulse ox runs chronically at 89, and that's their life. They've compensated, they've run there, that's them. You note it, you're fine, they're good, they're breathing fine, they're not struggling, it's good, but you document it and you pay attention. So you do a really good physical exam, and you rule out the simple stuff. Now, COVID is not like every other infection like the flu. The flu is kind of high fever, muscle aches, feel miserable. You know what it is. It's the flu. It kind of stays the same. COVID shifts around. It's a shapeshifter symptomatically. Not only does its symptom change, but the names are changing, right? So this summer, I think it was Nimbus, and this fall now it's called Stratus, which is XFG. So they're being creative with the names, which I appreciate because it's kind of fun, but it actually is very accurate. Because of the nature of the symptoms, they are shifting and they kind of flow together. Stratus and Nimbus, which are the two that are kind of summer and fall, both have that razor blade throat or really severe throat pain. And it's described like when you're swallowing, you feel like your throat's cut up with razor blades. As much as that was talked about, I didn't see that as much in practice. I saw that about half the time. Fatigue. This one, this fall, man, the fatigue thing is impressive. Back with Omicron and in the earlier COVID strains, early on, severe fatigue was really common. Then it got a lot less of a problem. Now it seems to be back. The cough doesn't seem to be as bad. The nasal congestion seems to be a little less a problem. The loss of taste and smell, much less of a problem. It does happen. The claim is, or the statement is from the higher-ups, that fever's very common and muscle aches. I don't really see so much of that. So that's a little bit of a confounder with the flu, right? You might think, maybe this guy's got the flu. And sure, maybe he does. In fact, looking back at the COVID days from the last 5 years, we do see that many COVID patients, they were called COVID patients, actually did have the flu. On retrospective analysis, they had the flu. They had fever and muscle aches. They had the symptoms of the flu, but they had the inaccurate PCR testing that showed they had COVID as well, and they preferred the COVID diagnosis and used that. So bad on them. But anyway, it's not a big a deal as now. Right now, fever and muscle aches not as big a deal. Not doesn't trick you as often as it used to. So sneezing, big deal. Really weird. Almost like you have like an allergy to cedar or something. Sneezing, a ton of it. And this is kind of the new thing that I think sets the latest COVID apart from previous, and almost might be the red herring that causes people to say, I don't know if it's a big problem. Digestive symptoms like nausea and diarrhea especially. And it can last for a week or two. It's claimed to be less common, but I see at least half the patients I'm seeing have bad diarrhea. Don't wait for lab testing. One, it's frequently inaccurate. And patients are going to get worsening symptoms. They're going to dehydrate. They're going to get all the stuff that goes with bad diarrhea and GI bugs, not swallowing because of the sore throat, fatigue and not getting up and drinking and eating, and start basic treatment. What is that? What is the basic treatment? Well, if we learned this back in 2019, we didn't know anything about it. 2020, we started to figure it out. By 21, I think everybody who was paying attention had this somewhere on a note, somewhere, either on their desk or stuck to a wall somewhere. This episode is brought to you by Esprit Health, the game-changing platform for cash practices that are ready to level up. With smart, intuitive AI tools that sharpen your clinical insight and streamline your business, Esprit Health helps you run a practice that's not just efficient, it's enjoyable. So if you're ready to break up with that cranky old EMR and finally experience tech that makes your life easier, come on over to EspritHealth.com and see how thoughtful technology can transform your practice. And hey, don't forget to subscribe so you never miss an episode that delivers the freedom to choose and the power to heal. Now, let's get back to the show. First step, Zithromax, 500 milligrams, 3 times a day for a full-size adult. A little less for a little person. That is because it has a very low inflammatory response. It's a static drug, not a cidal drug. It stops it reproducing. It doesn't blow the cell up. When you blow a cell up, you get this massive inflammatory response, which is what causes COVID patients to wind up in the ICU because they got this inflamed lung and this horrible situation for which steroids are very appropriate. But if you don't have to get there, why? Why even do it, right? So Zithromax is your antibiotic of choice to prevent secondary or superpneumonia. And for fever or the symptomatic management of fever, Motrin's a great drug. A couple hundred milligrams, tablet, 2 or 3 of them, 2 or 3 times a day for really high fever. 102, higher, patient feels miserable. Adults with a high fever will love you and thank you for the rest of their lives for putting them out of their misery with response to that alone. It's simple. And then aspirin. One of the problems that we've seen now is that a COVID infection without even without immunization, without an injection, can cause spike protein clots. And the 325 milligrams of aspirin once a day, very helpful. If you do that for 30 days, you're in the clear. You don't have to worry about it. Also, if you have some familiarity or comfort with natural medicine, I love nattokinase. I love serrapeptase. There's another called lumbrokinase. There's a whole bunch of really good naturally occurring blood thinning agents. Nattokinase is great because it's actually part of the spike protein detox protocols that are being used now to actually help patients who are recovering from previous either injection therapy problems or infection. And this is kind of the holy grail of viral treatment across the board, is zinc. Zinc is what your body uses to basically kill viral illnesses. And it does that by opening a cell, getting it into the cell, and then putting it into the system for destroying the virus. It can only do that if it has a proper ionophore. That means an agent that carries that zinc and puts it in the cell. We'll talk about it in a minute. And, little pro tip, a lozenge of zinc They're about 5 or 10 milligrams. They're real light, real low dose, but they're a great way to tell if you have too much zinc on board. So sometimes it's not convenient to test, or you don't want to test, or the patient doesn't want to pay to test, any of those things. You give them a zinc lozenge. If it tastes like they're sucking on a nail or chewing on aluminum foil, they have too much zinc, and you can back down. So that's a good little pro tip. Vitamin D. Vitamin D has been shown to be probably the single most important nutrient that you can track in a COVID infection that will prevent hospitalization and intensive care unit use. So if you take enough, 10,000 units a day, all of the days that you're infected, and at least for 30 days, you'll stay up in that 80 to 100 range that keeps you safe. Higher ranges above 50 seem to be preventive of ICU admission. Why it's that number, I don't know. I just know that's what the data shows, and that's great. Then finally, the ultimate anti-infectious vitamin of all time, vitamin C, our best friend. It's 1,000 milligram dose twice a day for 30 days. How do you know 1,000 milligram dose? Pro tip. This pinky tip is about 1 gram. That's about size. So a capsule about that size is about a gram capsule. So if a patient's asking you on the phone, hey doc, what is that? Say, that's about the size of your pinky tip. Then you'll know. So that's really easy. So everybody, if they look like they have an infection of any kind, C, D, zinc, easy. Say yes, okay? Then you can do the specific anti-COVID agents. You got the azithromycin on board, and now you're coming to the specific anti-COVID agent. Specifically, these are the things that cause people to get in all sorts of trouble and all sorts of hoo-ha at medical boards and the state level. And ivermectin. Ivermectin is an incredibly safe drug. It's been used for decades without a problem until the COVID spectacle became a thing. Proper dosing is somewhere between 0.5 milligram to 1 milligram per kilogram, split in half. So for me, about 60 milligrams split would be 30 milligrams twice a day, and that's the full infectious disease dose. You can take it 3, 4, 5 days. You can take it a little bit longer, but typically it's not needed for more than 5 days. Now, this is where COVID is set apart from every other infection and every other treatment plan and every other modality. This is where you and your patient partner, and you say to your patient, I know that ivermectin is safe if you do. If you don't tell your patient that. You figure it out and find out. Study the toxicity. Make sure you're comfortable. Make sure you can look your patient in the eye and say, I know this is safe, and I know you're going to be fine with this. And I know from my personal experience, when you treat a patient who has real COVID with ivermectin, they get better, and I don't want to over-exaggerate, but pretty much overnight. 24 hours, 48 hours later, they're better. They might not be all the way better, but they're better, and they're on the mend. I've had very sick, very old patients with very severe illness start on ivermectin, and the next day they're better. And then you do what every good doctor does. When you have a patient who's sick, who has a possible worsening outcome, and they have an illness that affects the respiratory tract, you give them precaution about going to the ER. Let them know if you have trouble breathing, go to the ER. Do not be afraid to go to the ER, because the ER will properly treat them and get them the oxygen that they need. Things are different now than they were 5 years ago. People are more aware. I don't think that necessarily everything will be handled perfectly, but you're way better off getting oxygen support when you need it than not. This is so easy to do right. It just requires you having a conversation with your patient where you listen to their story and you hear them, hear what they have to say. What do they want? Most people just want to be, they want to feel better. They also want to know that you care enough about them that you're going to keep them safe. I went to California over Thanksgiving with my son for the Thanksgiving celebration, and I had to deal with a bunch of his friends and their parents, and great people, but they don't know me personally. So the trust level is not there that I have here in my local community, where kind of what I say is gold, because I've been here for 30 or 40 years, so I have a high trust level. You need to create that trust level so that your patient understands and knows you well enough that they'll take your advice and run with it. You need to do that. Then you need to have them sign whatever forms you feel are necessary, because you're treating something that may be questionable. You know, somebody might not like ivermectin. They might have a question about it in the future. Make sure that the patient consented to it. And I wanted to let you know that you're paying attention like this, and your availability to the patient is critical to your entire community. The sense of well-being, the sense of peace and just really that life is okay when a provider like you is in the area. It changes their entire life when you're there for them when they really need you. The community of physicians and NPs and all of us, we kind of blew it in COVID in a lot of ways because we didn't take up for the patient as well as we could have. There were a lot of reasons for that. Not blaming you. I'm certainly not going to take blame because we treated COVID patients. But we were in a cash practice. We weren't in an institutional practice where we were forbidden from it. We stayed open the whole time. We could do it. And you know why? Because we were a cash practice, of course. That's your advantage. You can take care of patients in every situation. The only thing that's stopping you is you. So you can decide. Next time, when we get together, we're going to be looking into other ways that cash practice are liberated to provide critical support in diseases like cancer. Terrifying. So many tears have been shed in this office over that diagnosis, and so many tears of joy have followed up because of the results and because of the care that patients have gotten. Chronic infections like EBV and Lyme disease and heart disease and just all the things that you know that they're tough, and they're not simple answers. They require your intentional care. So thanks for tuning in to the Cash Practice Solution Podcast. I'm Dr. J. I'm here to remind you, a fulfilling cash practice really is within your reach, and we can help you get there. If you want to optimize your current cash practice or start a new cash practice, on the right foot, check out all our resources at thecashpracticesolution.com. So until next time, remember, listen to your patients, learn their stories, and love them with all your heart. You will be unstoppable.
Thanks for joining us. And if you have enjoyed today's conversation, be sure to hit subscribe so you don't miss out on future episodes packed with insights to help your cash-based practice thrive. And don't forget to check out all the tools and resources available at cashpracticesolution.com. They're free to you, and we're always adding more. Keep raising the bar in patient care. We'll reconnect in the next episode with more ways to help you succeed.